But anyway, I think that is my presentation, and thank you.
Thank you, Professor Said. The next speaker is Professor Akadiusz from Poland, and he will speak about the value of IBD in preventing pelvic ischemia in aortoiliac aneurysm.
Good afternoon. Chairperson, ladies and gentlemen, once again, I want to thank VSE board for inviting me here for this nice meeting. This is the topic of my presentation, and I am going to convince you that an endovascular procedure is better than the open ones, and see the value of the iliac branching in the preventing pelvic ischemia. These are my disclosures, and this is probably the most common picture of the aortoiliac aneurysm. Although, if you look into the ESVS guidelines from 2019, they usually focus on the iliac aneurysm instead of aortoiliac aneurysm. So what is the definition for iliac aneurysm? As you can see here is the dilatation 1.5 times from the normal diameter, and for the common iliac artery in men is 18 millimeters, for the women is 15, and the internal iliac artery bigger than the 8 millimeters for both genders are recognized as the iliac aneurysm. There is a certain threshold for the repair, and as you can see here, diameter should be bigger than the 35 millimeters, doesn't matter what iliac artery is involved. And there is also a classification for the iliac arteries based on the document of ESVS document guidelines. And as you can see here, the isolated iliac aneurysm are most frequent in the common iliac and the least frequent in the external iliac artery. But we have to remember that up to 40% of the cases of AAAs include also or contain also the unilateral or bilateral iliac artery aneurysm. So that's why we are facing quite often the problem how to repair these aneurysms. There are two possibilities, open one which was already presented and the endovascular repair. And if you look into the guidelines, obviously the first line therapy, it is recommended as an endovascular approach. If we have the case like this one, obviously, if the common iliac aneurysm is bigger than the 24 millimeters, you can imagine that the distal fixation is very difficult, and very often we can face the endoleak. So there is a sort of possibility how to treat them. Previously, we are trying to embolize the internal iliac artery and place the stent, which will be going from the common iliac artery down to the external one. But currently, having an IBD iliac branch device, obviously we are trying to preserve iliac artery just to allow the blood go into the pelvis. What is the technique? This is based on the Jotek technique, and this is iliac branch, which is inserted into the place where the iliac artery is. Then obviously we cannulate the internal iliac artery. We place the stent somewhere here, and then the main body is placed into the main aorta. I'm sorry, it looks much better on my computer than here on the screen. I don't know why, but anyway, then we connect the iliac branch in together with the main body, and this is, how it goes. And there are also anatomical requirements, and the important thing is the length of the aortic iliac bifurcation. It should be 50 millimeters, and the inner iliac bifurcation diameter should be more than 16 millimeter. And then the iliac landing zone, internal iliac landing zone, is also important, as you can see here. But anyway, if we have all these requirements, then we can go and do the technique of the IBD. What you can see here, on the left side, we have the position of the iliac branch device. We have to snare the O18 guide wire to the right side, and through that guide wire we place additional sheet which allowed us to cannulate the inner branch, and through that one obviously we can place the stent graft. And then what you can see here, the stent graft is extending the branch into the iliac artery, and this is how it really works. In year 2021, we published a paper, and we are trying to summarize our experience. What you can see here, this is the number of the all EVAR we did between the 2014 2020, and that was among them 37 patients with the IBDs, and that number now is much higher because we very like this technique. The demographic data is not different from the normal arterial ones, but what is interesting here, what you can see, the aortic aneurysm, it was in 30 cases, but the bilateral internal aortic aneurysm was in 23 cases. And that diagram shows you that the main indication for these patients were not the aortic aneurysm, but the dilatation, that means aneurysmal dilatation of the iliac arteries. This is our results. As you can see here, the technical failure we faced in 2 cases, stent graft thrombosis in 2, early in stage, in the hospital revascularization we had to do in 1 patient, and the local complication was only in 1. And these are 1 year, 1 month and 1 year results. 1A endoleak was at 1 month 3, we have to repair that, and at 1 year still we have to place the fenestrated stent graft. You will see that on this figure here. We had also 1B endoleak and endoleak type 3, which I'm going to show you in a moment. And this is a complication of 1 year. We had 1 death, 1 stroke, thrombosis of the iliac branch, and the stenosis of the eventus stent graft, which was expanding into the internal iliac artery. So let's see one of the case which was very interesting. What you can see here, the male is 63 years old with the aneurysm, aortic aneurysm only 43 millimeters, but the right common iliac artery 24, and the left, that was the main cause of operating him. What you see here, we made a certain design, and we operated him on year 2014, and what you can see here, to our surprise, everything was very well sealed on the left side, but suddenly it was 1 endoleak type 1B on the right side. We did, you know, the angio-CT 3 months later, and what you can see on the right side, the endoleak type 1B disappeared, and we were very happy with this. And then suddenly, year 2017, the patient came to us with a pain in the lower part of the abdomen, and what we found, we just put him on the operating table, and we did the angiography, and what you can see here, it is an endoleak into internal iliac artery. We made that closer here, and what we see here, there was a disconnection, in fact, in the stent grafts within the internal iliac artery. Then we came through the axillary approach. That was not so easy to cannulate the vessel here, but anyway, we did it. And through the wire, as you can see here, we placed additional, that time that was the Bentley stent graft just to seal everything. And as you see, the completion angiography was fine. The patient till now is stable without any additional endoleak. So ladies and gentlemen, in conclusion, I have to say that the iliac branch stent grafting is an effective technique, is feasible and safe, and especially is maintaining the antegrade flow, as you can see, to the hypogastric artery, preventing the buttock claudication as well as impotency. It offers a high technical success rate, although in some patients we can really face much more problems that even, you know, when you implant the thoracoabdominal branch stent graft. Sometimes it is very difficult to place the stents into the iliac arteries. So thank you very much for your attention.